Good morning. Thank you for tuning in. The Gastroenterology and Hepatology Advanced Practice Providers has created the MASLD Community Network to support clinicians in managing patients with MASLD or Metabolic Dysfunction Associated Steatotic Liver Disease and or NASH or Metabolic Associated Steatohepatitis. So my name is Tuesday Werner. And I am going to talk about lifestyle management. And I'm very honored to be speaking to you today. So this is the QR code to record your attendance for this meeting. And so we're going to start with our case study. Our patient is Albert, and he is a 65-year-old male with obesity, referred to our clinic for elevated liver enzymes and abdominal imaging with abdominal ultrasound, with remarkable increase in echogenicity or steatosis. So Albert is Hispanic. He is male and no alcohol since his 20s. Medical history includes type 2 diabetes mellitus, hypertension, hyperlipidemia, and laboratory tests showed triglycerides of 89, HDL 41, hemoglobin A1C of 72%, ALT with known elevation at least 3 years, about 1 to 2 times upper limit normal, and the evaluation for other causes of chronic liver disease is negative. On physical exam, patient has abdominal adiposity, no stigmata of advanced liver disease, and his BMI is 29. So, MASLD care pathway, the clinical decision tools have been updated to help guide the application of NITs or non-invasive modalities. So in this case, we will apply the MASLD AGA clinical pathway to show the patient's care. So primary care, endocrinologists, gastroenterologists, and obesity specialists should screen for MASLD with advanced fibrosis. So step 1, we have to identify the patients at risk. 2 or more metabolic risk factors, type 2 diabetes, and steatosis on any imaging modality or elevated aminotransferases. Then we'll need to go to step 2, which is taking history and laboratory tests. So exclude excessive use of alcohol and check for CBC, liver function tests, and then go to step 3, which is the use of non-invasive testing or NITs to check for fibrosis. Now, FIB4 is a calculated value based on age, AST and ALT, and platelet count. So depending on FIB4, we follow the guidelines. So FIB4 of less than 1.3 is low risk, and recommendation is to repeat the NITs in 2 to 3 years unless there's any clinical changes. FIB4 result of 1.3 to 2.67 is an indeterminate risk, and so if that's the case, you go to step 4, which is checking for liver stiffness measurement or LSM through FibroScan or the vibration-controlled transient elastography. And so based on the LSM score, let's say your LSM is less than 8 kilopascal, that's considered low risk. And again, the recommendation is 2 to 3 years check of NITs. And if your LSM is 8 to 12 kilopascal, that's considered moderate risk, and the recommendation is to refer to hepatologist for liver biopsy or MR elastography and monitoring and reevaluating the risk in 2 to 3 years. LSM of greater than 12 kilopascal is considered high risk, as well as FIB4 of greater than 2.67. So refer to hepatologist in that case. Now for our patient, Albert, so his FIB4 based on his ALT 43, AST of 38 and platelet of 170 is 2.22. He is considered indeterminate risk. And he had a FibroScan after that, and it is 6.7 kilopascal, which is considered low risk. So for him, the management is really lifestyle modification, optimizing metabolic disease management, and follow up to repeat the NITs. So for the MASLD continuum, MASLD, formerly called NAFLD, it refers to excessive fat accumulation in the liver in patients with metabolic dysfunction, not due to alcohol or other causes. MASLD is very common worldwide, and it's estimated about 30 to 40% of adults, depending on the population. Now, rates are much more higher among people with obesity or type 2 diabetes. Now, the key risk factors are really overweight or obesity, insulin resistance, dyslipidemia, hypertension, and that said, there's lean individuals that may also develop MASLD, but so metabolic health matters independently of the weight alone. So MASLD spans from the continuum of steatosis to steatohepatitis and to fibrosis ranging from 1 to 4. So usually fibrosis 3 and 4, it's advanced, but it can lead to cirrhosis as well. And once you get to cirrhosis, there's a possibility or tendency to have development of cancer or hepatocellular carcinoma. So the risk factors of MASLD is multifactorial, but let's talk about the pathogenesis as well, or genetics. So genetic molecular modifiers for MASLD, there's a variance of PNPLA3 or TM6SF2, MBO8T7, and GCKR. These are all influence the risk of liver fat accumulation, inflammation, and fibrosis. Now, epigenetic regulation, microRNA, DNA methylation, chromatin changes modulate expression of the key genes in lipid metabolism and inflammation. So really the key mechanism and steps, so you have this free fatty acid, de novo lipogenesis, and reduced lipid export leading to hepatic lipid accumulation or steatosis. And then the accumulation of toxic lipids and species or free fatty acids, as well as free cholesterol, can damage the cell membranes and mitochondria, etc. And then there's mitochondrial dysfunction and oxidative stress, leading to lipotoxicity and cellular stress. Then you have this activation of the Kuffner cells or liver macrophages and recruitment of the monocyte, and this produces pro-inflammatory cytokines, and therefore there's inflammation and immune activation, leading to chronic inflammation and cell injury, leading to the activation of the hepatic stellate cells and fibrosis, and then of course progression to cirrhosis and development of HCC or hepatocellular carcinoma. So again, MASLD pathogenesis is multifactorial. The disease progresses through stages from steatosis to steatohepatitis or MASH, fibrosis to cirrhosis, and possibly cancer via this variety of molecular, metabolic, or immune and environmental hits. Now, rather than the single cause, MASLD is understood via multiple simultaneous or sequential hits contributing to pathogenesis, which is like first hit, you have metabolic dysfunction, insulin resistance, causes lipid accumulation, and then further hits, you have lipotoxicity, oxidative stress, then immune activation, inflammation, and then there's this fibrosis as a response to chronic injury. And again, there's all these other things with the genetics, including gut microbiota, diet, and the quality, and the endocrine disorders, and etc. So how do we manage MASH? So the balance between nutrients and energy is crucial in the development of MASLD and MASH. We know that central obesity is the major promoter of insulin resistance and pro-inflammatory signaling. So step by step of what we currently know, there's obesity, especially central visceral fat. There's insulin resistance, type 2 diabetes, dyslipidemia, high triglycerides, low HDL, high LDL, and other multiple risk factors. So including this excessive calorie intake, diets high in sugar, especially fructose, saturated fat, like the Western diet patterns, and of course added sedentary lifestyles and low physical activity, plus the genetic epigenetic variants as mentioned before, and other hormonal issues like growth hormone deficiency. There's also age-related and sleep apnea. So think MASLD as a metabolic plus genetic plus environmental hits, and with the insulin resistance in the central drive, it's as a central driver, but modulated by diet, activity, and inherited susceptibility. So with the patient, with our next patient, the case of our patient, Albert, we know that lifestyle modification, all that, as we all go through to the next slide. Looking at the clinical study, we have this patient and we question him, or Albert, that, diet is also important. So we ask him about his diet, and he eats traditional Cuban diet consisting of mostly rice, beans, pork, corn, beef, and plantains. So as a nurse practitioner or a physician assistant or advanced practice experts, how can we best discuss this diet to our patients, and how do we tailor dietary recommendations to cultural preference and food accessibility, social economic status? So let's go to the next. Sorry. So as we said, the foundation of the management is really lifestyle modification. So lifestyle modification includes dietary change and exercise, which has been the mainstay, of course, before the resmetirom approval. Weight loss was directly linked to improve histologic outcome, and that we know that 5 to 10% weight reduction may resolve steatosis, MASH, or exert antifibrotic effect on MASH. So lifestyle is foundation. The benefits of lifestyle changes go beyond the liver: better glucose control, cardiovascular risk reduction, and improved quality of life. Moreover, improving lifestyle early can slow progression or possibly reverse early damage. So it is important to aim for gradual, sustainable weight loss rather than rapid crash diets, which often have poor long-term success or can be harmful. And even lean individuals, small reductions on preventing further gain may help. So again, lifestyle modifications, the mainstay of the treatment, including dietary changes and exercise with primary goal of weight loss. So lifestyle modifications, again, efficacy of diet and exercise treatment may be impacted by genetic polymorphism, as mentioned earlier. But here are the main components of lifestyle management. We watch for weight loss, we target and have strategies. Dietary changes, we include what types of diet, what to reduce, what to include. Physical activity, exercise, aerobic, resistance, how much and frequency. And most especially, I believe, behavioral and environmental support using counseling, goal setting, self-monitoring, etc. Each of these components is critical, and the best results come when they are combined. So high intensity interval training is not effective, especially as they review in the study. It was done in the study in 2023 resistance training not superior than aerobic. It's because the energy needed to invest in resistance is less than aerobic. Now, resistance equals aerobic, but resistance requires less energy consumption, as shown here. So exercise, usually we target greater than 150 minutes per week of moderate intensity aerobic activity. Sometimes brisk walking or maybe cycling or swimming. Resistance training, about 2 to 3 sessions a week, which is equally effective as aerobic for reducing hepatic fat, and it builds lean muscle, improves insulin sensitivity. And then the combination approach is best using aerobic and resistance. However, practical tips encourage gradual increase, start with about 10 to 15 minutes per day, tailored to mobility, preferences, and comorbidities of patient. And consistency matters more than the intensity. So again, back to the diet, calorie restriction to achieve weight loss is the mainstay. It promotes ketogenesis, genetic predisposition of personal response to specific diet, not clearly understood, and that Mediterranean diet is supported by ASLD, AACE, and European guidelines as a recommended primary lifestyle intervention. So really the goal is, goal is 7 to 10% weight loss, improves steatosis and inflammation and fibrosis. And then also limit sugary drinks, fructose, processed snacks, saturated fats, fried foods, processed meats, alcohol, avoid if advanced fibrosis or cirrhosis. Now encourage fiber-rich foods, vegetables, beans, whole grains, lean proteins, fish, poultry, tofu, beans, unsaturated fats, olive oils, avocado, and nuts. But then there's no single diet fits all, so tailor it to cultural preferences, budget, and accessibility. So dietary changes need to be sustainable, culturally appropriate, and tailored to individual preferences. So our patient, Albert, returns for routine follow-up with no improvement of labs. He admits that he has not begun any exercise regimen, but has been trying to cut out soda. So how do we work with patients to create behavior change? So behavior modification is a bridge between knowledge and action in MASLD care. Patients usually know they should eat better and exercise, but the challenge is turning that into a constant habit. So there's this exercise and diet adherence scale that we can use. It is a voluntary, it's a questionnaire at baseline and 6 months. And there's a 33 criteria check to monitor daily exercise and calorie intake. So a lot of times motivating patients, it takes time. So we usually do patient-centered approach, do motivational interviewing, do goal setting, self-monitoring, environmental modification, positive reinforcement, and stress and coping strategies. Do everything we can to incorporate multidisciplinary support, such as dietitian, physical therapy, exercise coach, and sometimes behavioral health. So really, it's about behavioral change, and it's incremental, and it requires really support and accountability. So for any other questions or information, you can visit the GHAPP MASLD Community Network for additional disease state education and Restifra webcast using this QR code. For anything else, I believe this is the end of my talk. We appreciate any of your feedback, and please reach out if you guys have any question.